Okay, just waiting another few moments for a few other participants to join us and then we'll kick off. Okay, we might get started then. So thank you for joining us tonight for this webinar on the Abatacept shortage. Just like to start by acknowledging country. So I'm dialing in from Gadigal country tonight, and so I want to pay my respects to elders past, present and emerging, and also to all the lands on which you're joining us from tonight, as well as any Aboriginal and Torres Strait Islander people who are present. So my name's Louise Hardy and I'm the National Policy and Government Relations Manager for Arthritis Australia. So thank you for joining us at quite short notice for this webinar, and we recognise obviously that the shortage might be causing you some concern. So we're hoping that this webinar will be an opportunity to give you some information and we have some panellists who can hopefully answer your questions as well. And we do want to highlight the importance of getting in touch with your rheumatologist as soon as possible to talk about your treatment. So joining us on the panel tonight, we have Neil McGregor, who's the Australia and New Zealand Managing Director at BMS. We have Elspeth Kay from the Therapeutic Goods Administration, and we have Professor Catherine Hill from the Australian Rheumatology Association. Just a bit of housekeeping before we kick off. So we do have a Q&A box, which you should see towards the bottom middle of your screen. So feel free to enter your questions in there as we go, and we'll do our best to get those answered for you. We are recording the session as well, so that we'll be able to post that on our website. So anyone who's missed it tonight will be able to watch that. And I think without further ado, we'll kick off, and I'll just hand over to Neil from Bristol Myers Squibb, who will be talking a little bit about the reasons for the shortage and what we're doing to manage that.
So good evening, everyone, and thank you very much for your time this evening. First and foremost, I think it's essential that I offer my unreserved personal and company apology for the shortage in Abatacept right now. We fully understand the seriousness of this and the impact this is having on patients and their families, as well as clinicians and pharmacies around Australia right now. This is absolutely a priority for myself and the company, and we are working and trying to find every possible means to resolve the situation in a timely and sustainable manner here in Australia. As you'll hear in through the various other panelists today, we've worked incredibly closely with the TGA, the ARA, which is the Australian Rheumatology Association, as well as Arthritis Australia and various patient advocacy groups. And I cannot say thank you enough for their partnership. With that, tonight's session's goal is obviously to minimise the impact for Australian patients, but it must come back to that and say sorry to patients who are today impacted by the shortage. Delivering our medicines to patients is a foundational competency of any pharmaceutical company, and one that we've been doing successfully with Orencia or Abatacept since 2007. We understand that the steady and reliable supply of our critical medicines for patients is an essential part of the role we play here in healthcare delivery in Australia. From January 2022, in what has been a rapidly evolving situation, we have had low and intermittent supply risk globally. And one of the questions I've had from many stakeholders is this something that relates purely to Australia, or is this something that goes beyond the Australian borders? The reality is this is a global shortage that is impacting a number of countries around the world right now. Now, the reasons for the shortage, which is the piece to kick off, and I look forward to taking questions from the stakeholders later today, is around three major issues. We have seen increased global demand for Abatacept, but at the same time, we've had manufacturing and production capacity constraints, including some of the component parts of our product being in delay. At the same time, the overview of COVID and Omicron and delivery schedules has proven this challenging, and as such is related to the shortages we see currently. On a daily basis, we are currently looking how we can work with our global stakeholders to manage this to a resolution as soon as possible. And we're looking at two key elements. Number one is how can we remove our capacity constraints? And we're looking at both internal manufacturing and external contract manufacturing in order to boost the availability of Abatacept globally, but more importantly here in Australia. At the same time as we're looking at how we can alleviate some of the challenges that relate to the actual component parts of the product. It is really important today that you'll hear there is no quality issues with the product of Orencia in the market. This does relate to just intermittent stock supply. The product of Orencia that's in the pharmacy right now is of quality and consistent with the TGA product. We have and will continue to work with the TGA and the ARA about a process of how we will allocate stock. The purpose of that is to make sure that patients who need our product are allocated that, and it's not a lottery of who gets our product. We understand our product's unique benefits to patients, and we need to work together in that partnership way to make how we can solve this for patients. There is clear processes that we'll go through that's using in partnership with the TGA and the ARA. And like any process, there is likely to be some teething problems. And we, based on the feedback for today and future things, we will continue to work through those challenges in order that we can minimize the impact for patients, pharmacists, and physicians. With that, I do want to say that this is an incredibly challenging situation, and I unreservedly apologize for the shortage of supply of Abatacept. And thank you everyone who's involved in supporting us through this period, but most importantly, working for patients to make sure that the impact is minimized. So with that, I'll pass to Elspeth, who will take us through from the TGA, some of the perspectives are working in line with the government's policies and processes to kind of work together to fix this. So Elspeth.
Thanks very much, Neil, and thanks to Arthritis Australia for having me along this evening. My name's Elspeth. I'm from the TGA, we're Australia's medicines regulator, and we play a role in assisting when there's a shortage of a medicine. So pharmaceutical companies are required to tell us when one of their medicines is going to go into shortage. We publish that information on our website so that it's available for health professionals and consumers. And when we identify a shortage that's likely to have significant impacts for patients, then we work with a range of different stakeholders, including the pharmaceutical companies, with consumer and health professional organisations to coordinate communications about that and to find ways to try to minimise the impacts on patients. So since we first learnt of this particular shortage, we have been working closely with BMS to look at what management actions we could put in place to reduce the impact of the Abatacept shortage. And I'd also like to acknowledge the challenges that this shortage presents for consumers and for rheumatologists, and particularly given that this comes quite soon after the tocilizumab shortage. I know that some people may have been affected already by the tocilizumab shortage, and I'd like to acknowledge that a second shortage of a medicine used to treat arthritis may be quite distressing and difficult for you. So one of the things that we've done to address this particular shortage is put in place a serious scarcity substitution instrument. So as Neil said, through this shortage, there will be limited supply of the two subcutaneous presentations of Abatacept. So that's the ClickJect autoinjector and the prefilled syringe. Now, there is a limitation on supply and a temporary ordering system in place to help make sure that that limited supply is available for the people who have the most limited alternative options. And I know Catherine will speak about that in a little more detail in a moment. So your specialist may need to change your treatment. And if you are on Abatacept prefilled syringe or the auto-injector, then we encourage you to talk to your rheumatologist as soon as possible about your treatment. But if you are staying on Abatacept, then it is possible for your pharmacist to dispense whichever of the subcutaneous presentations that they have in stock at a particular time, regardless of what your prescription says, so that you don't need to go back and get another prescription. So as long as you meet the specific conditions, or your pharmacist judges that it's appropriate to make that substitution, then they can do that, and they'll let the prescriber know that they've made that switch afterwards. And the medicine is still substituted, still covered by the PBS, even if the pharmacist substitutes it for you. Now, the pharmacist will show you how to use the substituted medicine, or they'll refer you to your specialist or a GP or rheumatology nurse to show you how. So that mechanism that allows pharmacists to do that switch is in place at the moment until the end of April, but we will extend that to cover the entire period of the shortage until supply of those two products is normalised. You might have seen that we've published information on our website. So there's a web statement up on the TGA website with some more information about this. We've also done some social media posts about it, and we've provided information to pharmacists about that substitution instrument. So Catherine will talk a bit about the form to take to your pharmacist if you are staying on Abatacept. So if your rheumatologist gives you that form, you need to give it to your pharmacist with your script, and that's needed for your pharmacist to order Abatacept. So finally, I'd like to thank all the stakeholders who've worked with us on this: BMS, the Australian Rheumatology Association, and Arthritis Australia. So we'll continue to work with all of those stakeholders and update communications as we hear more about this shortage. Thanks very much, and I'll pass over to you, Catherine.
Thanks everyone. Thanks Elspeth and Neil and Louise and the Arthritis Australia for organising this webinar tonight. So I'm Catherine Hill. I'm President of the Australian Rheumatology Association, which is the professional association of rheumatologists and rheumatology healthcare professionals. And almost every rheumatologist in Australia belongs to our association. But my other hat is I'm a rheumatologist at the Queen Elizabeth Hospital in Adelaide. So I wanted to talk about what we've been doing as rheumatologists with this shortage, and as Neil alluded to, you know, very soon after the tocilizumab shortages. So what have we been doing today? We've representatives of the ARA have been meeting with other groups and been in contact with the TGA, Bristol Myers Squibb and Arthritis Australia, and we've been meeting regularly so we can discuss the best way to manage the supply to reduce the impact of the current shortages on those taking Abatacept. So as alluded to, Abatacept actually comes in 3 different forms. There's an intravenous form, which was actually in short supply for a short period at the end of the year, and then actually is more available at the moment. And then we've got 2 subcutaneous presentations, a prefilled syringe and a ClickJect, which you might be on. So I saw in the chat that several people said that, you know, there was absolutely no supply, and that was actually true, that there was almost no supply of Abatacept till about a week ago, when there was a shipment brought in, and which was the prefilled syringe. There's enough currently for about 50% of people who are currently using Abatacept. So in Australia, there is about 4,000 people with rheumatoid arthritis who are using Abatacept. The next slide. So what we've done is we've been working with these groups to develop a guidance on the prioritisation of patients who should stay on Abatacept during the shortage. And this is really difficult because we know that many of you who are on the drug are getting a very good benefit from it, which is why you've been continuing on it. But the reality is only about 50% of people can stay on. So we do need to prioritise those patients who really need it. So we're in consultation with the other groups as well as rheumatologists within the ARA. We've got some recommendations. So firstly, that no new patients be initiated on Abatacept, because that would actually just exacerbate the problem. Patients be moved off Abatacept if possible. And we don't want patients to move from the subcutaneous injections to the intravenous injections either, except in exceptional circumstances. And that's because the number of people on intravenous is very low. And if we move a lot of people to the intravenous injection, we'll actually just run out of supply for all of those people. So we want stock to be conserved for patients who have used 2 or more biological targeted synthetic DMARDs prior. So we know that these group of people who have tried quite a few other drugs and they haven't worked, and that's why they're on that's why they're on Abatacept. Or if you have reasons that you can't take other biological or targeted synthetic DMARDs. Now, these are going to be decisions that will need to be made in consultation with your rheumatologist, because they will know your disease and your current and previous treatments the best. Next slide. So BMS have developed a process to facilitate ordering for patients who meet these ARA guidelines. And so what that means is, with your current script, if you took that to the pharmacy, they won't be able to dispense the Abatacept without this patient eligibility form. Now, this patient eligibility form needs to be filled in by your rheumatologist. So if your rheumatologist decides that you meet the criteria to remain on Abatacept, then they'll fill in a form and you will take that to your pharmacy with your prescription, and they will be able to order stock for you. As Elspeth mentioned, there's also B measures in place so that you can easily swap between prefilled syringe and ClickJect autoinjector at the pharmacy without getting a new prescription from your rheumatologist. The way the supply, we understand, is coming in from BMS is that there's prefilled syringes, but likely the next shipment will be the ClickJect. So that means almost every patient who stays on Abatacept will need to change between these 2 forms. The ARA has been in constant communication to our rheumatologist members through various means, including a webinar, which we held last week, for rheumatologists, emails and newsletters. So your rheumatologist should be well aware of these issues and the eligibility form that's required. So we've also requested that changes be made to the prescribing of biological DMARD. So if a patient switch off Abatacept, to make that process easier for both patients and rheumatologists. So our key messages for you are, like Neil and Elspeth, I'm really sad that we're having to make these decisions, but we do have to reduce the current usage by 50% so that we don't run out of Abatacept for those most in need. If you are on Abatacept, then I urge you to be in contact with your rheumatologist as soon as possible, just to discuss your treatment. And if your rheumatologist thinks that you need to stay on Abatacept, then they'll need to fill out a special form for you to take to the pharmacy so that it can be dispensed. And it's important to remember that you can go back on Abatacept once the shortage is eased, if that is the best medication for you. And currently, our information from BMS is that the shortage is likely to ease mid-year. So I'd also urge you to also remember and talk to your rheumatologist about the fact that there has been quite a few newer medications that have come out since Abatacept was released. So this may be an opportunity for you to try one of the newer biological or targeted synthetic DMARDs that are now on the market. So I'd like to leave it there and hand back to Louise, and perhaps we can take some of your questions.
Okay, thank you very much, Catherine, Elspeth and Neil, for your presentations. So we will move on to questions. I see that we've got a number of questions in the Q&A tab as well as the chat tab. If possible, if you can put them in the Q&A tab, just so that we can make sure that we're covering everything off for you. So I'll start with this one. Given authorities have been aware of the shortage for many months, is there a reason these substitution and hypercare plan processes have taken so long to be implemented, especially as we had the tocilizumab shortage as something to learn from? Did anyone in the panel want to field that one?
I can answer that one, Louise. So it's certainly true that the tocilizumab shortage did help us in thinking about how to manage this shortage, particularly the fact that we had worked together previously with Arthritis Australia and with the ARA on managing that previous shortage. We first found out about this shortage at the end of January, and we notified people of the shortage at that point through a notification on our website. Since then, we've been working closely with BMS and with ARA on management strategies for this particular shortage. So I know that BMS has been trying to expedite orders over that time, and we've been working together on some coordinated communications, as well as the other measures like the hypercare plan and the serious scarcity substitution instrument to allow that swapping at the pharmacy level.
Okay, thank you, Elspeth. Did anyone want to add anything before we move on to the next question? No, thank you. Can BMS advise which pharmacies have supply? It's impossible to find anywhere right now, so the form won't help.
I think from my perspective, following Catherine's presentation, the reality is there's this process where the pharmacist needs to contact. We'll put in the chat here how the pharmacist connects that. We have connected through the Pharmacy Guild about the process and with the rheumatologists of that. We can make that aware. Equally, both at the ARA or Arthritis Australia or at Bristol Myers Squibb's MedInfo line, you can contact us and we can help connect your pharmacist with the associated form. It is worth noting that under the process that the pharmacist form is part of the process. It does require the rheumatologist to have that criteria and the counsel with the patient. And that is to do, as we said, we have scarcity of supply in the short term, and we need to think about how can we optimize this in this difficult situation, working with the physicians about which patients across Australia are best suited to either switch to an alternative treatment or stick with Abatacept while we're in the scarcity of supply. I don't know if Catherine, if you want to add things. The process is for patients to talk to the rheumatologist, and then the rheumatologist will function the supply via a pharmacist under the current process.
Yep. Once your pharmacist has got the patient eligibility criteria signed off by the rheumatologist, it's pretty clear on there what the process is for them to go back to BMS and get supply. And that supply will be for you if you've
Correct.
had that filled in. It won't be something that will sit on their shelf and they could give to the next person who walked in the door. It will be for you.
Yeah.
Okay, thank you for that. We've got another question. If you change biologic, can you change back at a later date?
Yeah, I'm happy to take this one. Yes, absolutely. You'll be able to change back at a later date if you find that if you prefer to go back to Abatacept. I think someone mentioned the Actemra shortage. So the Actemra shortage is starting to ease, and so at the moment some patients are actually moving back to Actemra if they'd been changed to another biologic. So that absolutely will be the case.
And can I just add maybe on this one of the pieces here we've said is we have 3 different formulations for this product between the ClickJect and the prefilled syringe. We have, which will be in the Q&A perspective on our Orencia Go website, which will show you the practical implications of the various different devices that require for Abatacept. So you may well be on ClickJect today, and right now there's prefilled syringes, and that's a slightly different device, exactly the same pharmaceutical product in it, but there is some challenges or changes for you as the patient in administering that, and both the pharmacist and yourself can access those pieces in collaboration with your rheumatologist as well.
Okay, thank you, Neil. So I think this question is probably partly covered just now, but the question is that the shortage of Actemra was supposed to have eased in January 2022, and that has improved. But the question is, what assurance is there of the return of supply?
So I think I should take that. The reality is we have supply plans that we're working to expedite as soon as possible. We have signaled that this is an issue that we're going to see in the coming months, and at the moment through to the first half of this year. We're doing everything we possibly can to remove this shortage as soon as we possibly can. But we signal at this point in time, our best information is that this will take through to the mid of this year, and that's our latest information. We do share that transparently and regularly, both with the TGA and with ARA, so that we can clearly update stakeholders as that changes. As we said earlier, this is a dynamic situation that has happened quite quickly since January. And we need to continue to have that high level of communication across the stakeholders so that we can reform and refine the processes as needed.
Thank you. We've got another question for BMS, and this question is saying that it's a second Orencia supplier breakdown in the last few months. Why didn't BMS learn from and not repeat the problems?
So the reality, the perspective is the previous one was on our IV indications. Those are a different manufacturing setup and has different challenges. Through the COVID period, as we said, there's been multiple things around manufacturing and obviously scarcity of supply of some of our component products. And this is a dynamic situation that we can constantly are looking at. So whilst they're related in the product, they are somewhat different in terms of the root cause.
Okay, thank you, Neil. So we've got a question about switching back. So is there a possibility that once you change back, the medicine will be less effective? Catherine, did you want to comment?
Yeah, so there's one small study where a group of patients were stopped with Abatacept, and then they were switched back on, and about 80% of patients regained the effect. So if switching back might not be as effective, unfortunately, but it will be a small proportion of people. Yeah, that's reality, if I wanted to be truthful with you. So in almost all cases, people will gain the same degree of control, but not in absolutely everybody.
Okay, thank you, Catherine. So we've got a question. Can you explain why this medicine is supplied direct to pharmacy instead of via a wholesaler? Pharmacists find this challenging to find out information about the medicine and also order it in quickly.
This is a choice in Bristol Myers Squibb. So this is a cold chain product that has specific quality requirements to make sure that the product remains in line with the label and quality constraints we have with TGA. We look at this across our cold chain products are all direct to market, which means that we actually have specific access to specific pharmacies. This is just a choice in terms of the quality product that we believe is most efficient in delivering the medicine in an efficient, effective way, given some of the quality challenges that we have. And that's just the Bristol Myers Squibb operating model for our cold chain products.
Okay, thanks, Neil. So we've got another question about supply restarting for the total of 4,000 odd Australians who are affected. So I think we probably did cover this to some extent previously, but just if there are any other comments you wanted to make at this point. Okay, we'll move on.
I just wanted to maybe comment on the fact that rheumatologists, your rheumatologist has no influence about supply of medication. That's BMS and it's also the TGA's role. We've stepped in as the professional association because we are very close to patients, we're prescribers, and that's why we've stepped in to work with Arthritis Australia, with the TGA and with BMS. But the rheumatologists, we don't get any earlier news of shortages than consumers. But that's why we've been so proactive as soon as we've seen shortages, we've been stepping in and organising meetings and trying to do the best thing for our patients, which are all of you.
Absolutely. I just think it's important that I do endorse this. The reality, the stock shortage is Bristol Myers Squibb's in partnership with the TGA. ARA have been spectacular along with Arthritis Australia in dealing with the challenges to mitigate the perspective. But the shortage is a function of Bristol Myers Squibb, and now working in partnership where TGA has experience about how we can minimize that. But to Catherine's perspective, the Rheumatology Association are providing us help and guidance about how we can best minimize this. The perspective around the stock shortage is between Bristol Myers Squibb and the TGA, who have been, again, strong partners in working through this. I echo Catherine's perspective.
We've got a slightly broader question now. So it's about what process is being used to monitor other biologics and stockpile if necessary. In general, what sort of inventory is being kept in Australia for approved biologics that are being used in Australia? Elspeth, is this something you wanted to speak to?
Yeah, look, I can certainly speak to that one. So we have a process, apart from pharmaceutical companies telling us of shortages that they're expecting when they identify issues with their own supply chain. We also proactively monitor some medicines where we perceive that there may be a risk. And certainly in the arthritis space, because we have seen shortages of some medicines, we anticipate that there could be knock-on effects to others. And so we are taking a proactive approach. That means working with sponsors, asking them for information about their stock holdings, asking them whether they perceive any risks coming up so that we can get as much visibility as far ahead as possible of any supply interruptions and hopefully work with sponsors to prevent interruptions to supply before they occur.
Okay, thank you, Elspeth. So I think we're down pretty much to our final question now. So someone has said that they've found restarting after skipping Orencia doses for COVID vaccination, that it doesn't seem to be effective. So this person's very concerned about stopping and restarting.
Yeah, that's really interesting that you found that. I think this is something where you really you need to make an appointment to see your rheumatologist and discuss that with your rheumatologist, because it may be that stopping Orencia isn't the best thing for you.
And just to echo that perspective, I believe I'll put some information around our medical information centre at Bristol Myers Squibb. It's important that we also learn that insight so that we can seek other patients who have that experience, so that we can work with rheumatologists around the world to understand if that is something that we should be aware of. But to your perspective, the first piece is obviously see your rheumatologist for your specific circumstance. I do think it's important, just echoing my second perspective, we have, whether it be Arthritis Australia, we are making sure that our information and our resources at Bristol Myers Squibb are available, whether it be our website, as we talked about, for specific things around Orencia or concerns patients have. Please, we'll put those there and we will continue to work through those pieces. We do take ownership for the challenges you're in. The key piece that, as we said today, is from a patient perspective is your rheumatologist will help you understand whether you call it in the short stock shortage period, and then we can provide that stock to pharmacy in a timely manner. And I do unreservedly apologise for the stock shortage and the inconvenience this is causing you. And at the same time, thank, again, ARA for helping us to create the criteria. Again, they are helping us create that criteria, not this is something for Bristol Myers Squibb and the TGA. And we'll continue to work through this, and my team will do all and everything to reduce this and minimise the impact as soon as we possibly can here in Australia.
Thanks, Neil. We've had a few extra questions pop up. So when I did my last call there, so I might just work through those. Someone has asked for a bit of a brief recap just on the reasons for the shortage, and obviously we will post this webinar online tonight. But Neil, I don't know if you would mind just giving a brief recap of the reasons and maybe speaking to another question we have about why can't BMS make more Orencia at the moment.
So the perspectives of the reasons is it's multifaceted, the reason, and again, in that dynamic perspective coming out of July. The first piece is that we have seen for Abatacept worldwide a higher level of global demand. At the same time, our manufacturing and production capacity has been constrained, and we've had some challenges with the supplier component parts that relate to the Abatacept prefilled syringe and our ClickJect. The addition of that, we have had some challenges relating to COVID as it relates to Omicron and the delivery schedules through the early half of this year. So it's a combination of all different elements. And what we're working on right now at Bristol Myers Squibb, across myself locally and our global team, is how do we increase remove capacity constraints? So by internal manufacturing and external contract manufacture. The product, as you can imagine, is quite a complicated biologic to create, so that it's not something that we can stand up a manufacturing site instantaneously and gain that additional capacity. Things like, for example, and then there's supplier constraints, as you can imagine, through, as we see medical glass globally across multiple therapeutic areas right now, is under constraint. So we're working through each of those issues. So Louise, and the second point of the question is, why can't we just do that? I think it goes to our perspective, which is consistent with the TGA, the quality use of our medicines, the quality checks to make sure that the product that's received by a patient at its end form remains the highest quality throughout the world at this point in time, and no shortcuts are taken, so that we can maintain that credibility of the quality of the product that patients receive. I don't know if the TGA would like to add anything, Elspeth, if there's anything that you have.
I don't think there is really anything for me to add, Neil, but I agree, it's a complex product to make, and there are, apart from the complexity of standing up a manufacturing site, there are certain hurdles that regulators need to, that companies need to jump to ensure that they are providing a quality product, and so it's not a short-term solution, unfortunately.
Okay, thanks for that. We've got a question here about, or a couple of questions about communicating with the patients or the consumers. One of the most challenging things is communicating to the patient and how they can find the right information in a timely manner. Could there possibly be an opt-in medicine shortage registry for patients where they could be alerted of shortages directly and what their options are, instead of them having to seek answers from multiple sources?
It is possible to subscribe to an email alert about medicine shortages. I would say that it includes all shortages that we're notified of. So at present, it's not possible to just ask to be sent shortages that relate to a particular therapy area. We're continually working on how we improve our communications, and certainly the idea of being able to opt into specific types of shortages has been on our list of things that we'd like to do in the future. We also work with a range of different consumer organisations who form a champions network for us to help get messages out to particular patient groups when there are shortages that affect those groups. And we're always very interested in hearing other ideas for ways that we can improve our communications.
Maybe if I can just add to that perspective. So obviously there's Arthritis Australia, where we'll continue to give the latest information, and I think they've given us the opportunity to make sure, and also other patient advocate organisations, because I know that there are numerous across Australia. So we are continuing to try our best on that perspective. Also on our Orencia website, trying to give as many one-stop shop and understand the frustrations in this. If there's any specific perspectives, again, we're going to put our med info line on the Q&A here. Please tell us what you're looking for, and we'll try and see how we can work with the stakeholder groups, and that's on Bristol Myers Squibb to simplify that for you. So we'll take that under perspective, and then working with our stakeholders and see how we can simplify that.
Thanks, Neil. I should add, from Arthritis Australia's perspective, obviously we're trying to make sure that we do reach out to consumers through our channels to provide the most up-to-date information as well. And if you do need support, we have the Arthritis info line that you can call, and the number for that is 1800 011 041. And as Neil mentioned, there are other organisations like MSK Australia and ClickJect who do also provide support to consumers, because we realise this is a really difficult issue that you're being confronted with. A couple of more questions have popped up. So what are the typical alternative biologics to Abatacept? Catherine, or anyone who wants to field that one?
Yeah, I think that's going to come to me. So we are actually pretty fortunate in Australia. We have on the PBS, we have a broad range of biologic and targeted synthetic DMARDs available to patients with rheumatoid arthritis. So that's up to 12 now. So there are quite a few alternatives. The reason why we've prioritised people who've tried several others is there are certain classes of drugs. So things like, I won't go through all of them, but there's TNF inhibitors, there's the JAK inhibitors as well, which are the new oral agents. So as well as rituximab and and the TNFs that I mentioned. So there are a number of alternatives, and some of those might have become available since you've started on Abatacept. So it might not be a bad time to try one of the newer agents and see whether that's also suitable for you. But you will have the chance to go back. I do notice that someone had mentioned that Roche is telling people that there is currently no supply available of Actemra. Now, the ARA and Arthritis Australia have had several meetings with Roche over the past couple of weeks, and they've indicated to us that there is an easing in the supply, particularly the subcutaneous. We are happy to, the ARA is happy to go back to Roche and question them about that.
Thanks, Catherine. I think we've got another one that looks like it's got your name on it there about whether it's advisable to swap back to Actemra at this time rather than try yet another biologic that may or may not work. And again, you've probably covered the availability of supply.
Yeah. So when we've looked at the new, given that there is easing of the supply, patients who've moved from tocilizumab to Abatacept and then find themselves again in a shortage, we've prioritised that group of patients to be the ones to go back onto tocilizumab, because we recognise that you've had 2 episodes of drug shortage, which should never, which is really terrible, and we're prioritising people like you to go back onto Abatacept. So I would, if your arthritis was under good control with tocilizumab, then talk to your rheumatologist about being swapped back to that.
Okay, well, thank you all. I think we've probably run dry of questions. Obviously, any questions that you want to follow up on, feel free to contact Arthritis Australia. Wanted to thank our panel very much for attending tonight, and I know that everyone has been working really hard to manage this situation, which we all recognise as very unfortunate and is having impacts on you as consumers that are really nothing that anyone wants to see. So thank you all, audience, for attending and for asking your questions. I hope that we've been able to answer them in a way that's answering your questions tonight. We will be making a recording of the webinar available on our website, so we'll get that up as soon as we can for anyone who's missed it. And again, if you want to reach out to Arthritis Australia or one of the other consumer organisations for support, obviously we do have some support and some resources available. So thank you very much, everyone. I think with that, we'll close the session.